If you're over 70, you may think more testing means better protection. But what if I told you some routine health checkups after 70 can actually cause more harm than benefit? I'm Dr. Leonid Kim, MD, and today we're going to talk about 5 common medical tests that many seniors continue, even when the science shows they may not improve lifespan, quality of life, or overall health. This is not about avoiding doctors. This is about avoiding unnecessary harm. Because after 70, your body changes, and preventive medicine must change with it. Let's go step by step. At 70 years old, many men believe the smartest thing they can do is test more, scan more, and search harder for hidden disease. It feels responsible. It feels proactive. It feels safe. But what if one of the most common tests ordered in men over 70 is quietly causing more harm than protection? What if the very blood test meant to save lives is, in some cases, stealing quality of life instead? The PSA test, prostate-specific antigen, has been a routine part of men's health conversations for decades. It measures a protein produced by the prostate gland, and elevated levels can sometimes indicate prostate cancer. That word alone, cancer, is powerful enough to trigger fear, urgency, and immediate action. But here is what most men are never fully told. After the age of 70, the science changes dramatically. The U.S. Preventive Services Task Force, after reviewing years of clinical trials and population data, concluded that routine PSA screening in men over 70 offers little survival benefit for most individuals. Why? Because many prostate cancers in older men are slow-growing. In fact, autopsy studies have shown that a significant percentage of men in their 70s and 80s have microscopic prostate cancer that never cause symptoms, never spread, and never shorten their lives. These are called indolent cancers. They exist quietly, they grow slowly, and they often die with the patient, not because of the cancer. But the PSA test cannot reliably distinguish between a slow-growing tumor and an aggressive one. A slightly elevated number can trigger a cascade. Repeat blood tests, MRI scans, needle biopsies, and biopsies are not harmless. They can cause bleeding, infection, hospitalization. For an older immune system, even a small infection can become dangerous. And if cancer cells are found, even if they are low risk, the psychological weight is enormous. Very few people are emotionally prepared to watch and wait once they hear the word cancer. And that is where overtreatment begins. Surgery to remove the prostate may eliminate a tumor that was never going to cause harm, but it can permanently change a man's life. Urinary incontinence, erectile dysfunction, loss of sexual confidence. These are not rare side effects. They are common outcomes. Radiation therapy carries its own risks: bowel irritation, fatigue, bladder problems. For a 72 or 75-year-old man who was living actively and independently, these complications can quietly erode quality of life far more than the original slow-growing tumor ever would have. Large clinical trials, including data reviewed internationally, have shown that the mortality benefit of PSA screening decreases significantly with age, especially beyond 70. That means fewer lives are saved compared to the number of men harmed by downstream procedures. Medicine is not just about detecting disease, it is about balancing benefit against harm, and after 70, that balance shifts. This does not mean prostate health should be ignored. It means the strategy must evolve. Instead of automatic annual screening, decisions should be individualized. Life expectancy matters. Overall health matters. Symptoms matter. A healthy 71-year-old marathon walker is different from a frail 88-year-old with multiple chronic conditions. Personalized medicine becomes essential. There is another truth rarely emphasized. Chronic inflammation and metabolic dysfunction are major drivers of prostate enlargement and possibly aggressive cancer progression, and those are heavily influenced by lifestyle. Diets rich in processed meats, refined sugars, and trans fats increase inflammatory markers. In contrast, populations consuming Mediterranean-style diets show lower rates of aggressive prostate cancer. Cooked tomatoes provide lycopene, a powerful antioxidant studied for prostate cellular protection. Fatty fish like salmon supply omega-3 fatty acids, which reduce inflammatory signaling pathways. Pumpkin seeds contain zinc, essential for prostate tissue health. Green tea polyphenols have demonstrated anti-proliferative effects in laboratory models. These daily choices do not create headlines. They do not produce dramatic numbers on a lab report, but they influence the internal environment in which cells live. And cancer biology is deeply connected to that environment. After 70, strengthening the terrain of the body often matters more than chasing small fluctuations in a blood marker. Fear is a powerful driver in medicine. No one wants to miss something. No physician wants to overlook an aggressive cancer. But the evidence reminds us that more testing is not automatically safer testing. Every intervention carries risk. The question becomes, will this test meaningfully extend life, or will it simply detect abnormalities that were never destined to cause harm? Men over 70 deserve honest conversations, not automatic protocols. They deserve to understand that survival statistics are averages, not guarantees. They deserve to know that quality of life, continence, sexual function, independence is a critical outcome measure, and they deserve to be empowered to ask a simple, powerful question. If this PSA test is elevated, what exactly will we do next? And will that action truly improve my remaining years? The science does not argue for neglect. It argues for wisdom. For some men over 70, especially those with strong family histories or excellent long-term health, screening may still be reasonable, but it should never be reflexive. It should never be driven by fear alone. It should be a thoughtful decision grounded in evidence and personal values. As medicine advances, longevity is increasing. More men are living into their 80s and 90s. That makes decision-making even more nuanced. A test that made sense at 55 does not automatically make sense at 75. Biology changes. Risk profiles change. Complication rates change. And the definition of benefit changes. Perhaps the most powerful shift after 70 is this. Prevention becomes less about detecting silent disease and more about preserving strength, mobility, cognition, and joy. Strength training preserves muscle mass that protects against falls. Cardiovascular exercise maintains vascular health that protects the brain. Anti-inflammatory nutrition stabilizes metabolic function. Social connection reduces stress hormones that impact immune balance. These factors consistently show stronger associations with healthy aging than aggressive cancer screening in low-risk older adults. So when you hear that more testing equals better prevention, pause. Ask for context. Ask about guidelines. Ask about the data. The U.S. Preventive Services Task Force did not make its recommendation lightly. It reviewed decades of research to conclude that for many men over 70, routine PSA screening offers limited benefit and substantial potential harm. In the end, health after 70 is not about fighting every microscopic abnormality. It is about protecting the life you are living now. It is about choosing interventions that add vitality, not anxiety. And sometimes the most courageous medical decision is not to test, but to focus on the daily habits that truly determine how well you live in the years ahead. For decades, colonoscopy has been described as one of the most powerful tools in modern medicine, a procedure capable of preventing cancer before it even begins, a screening that has saved countless lives by detecting and removing precancerous polyps early. Between the ages of 45 and 75, the data is clear. Colon cancer screening reduces mortality, and colonoscopy plays a critical role in that success. But something profound happens after 75, and almost no one talks about it openly. The balance between benefit and harm begins to shift quietly, gradually, and sometimes dangerously. The human body at 78 is not the same body at 58. Blood vessels are more fragile. Healing is slower. The heart is more sensitive to sedation. The kidneys are more vulnerable to dehydration. And yet, many older adults continue routine colonoscopies simply because they have always done them. Because it feels safer to continue than to stop, because stopping feels like giving up. But evidence-based medicine tells a more nuanced story. The American Cancer Society recommends that for adults aged 76 to 85, the decision to continue colorectal cancer screening should be individualized based on overall health, prior screening history, and life expectancy. After 85, routine screening is generally not recommended. Why would one of the most respected cancer organizations in the world advise caution? because the scientific data shows that after 75, especially in individuals who have had consistently normal prior screenings, the likelihood that a new polyp will progress to life-threatening cancer within their remaining lifespan becomes significantly lower. Colon cancer typically develops slowly, often taking 10 to 15 years to evolve from a small polyp into an invasive malignancy. For many older adults with other medical conditions, that timeline matters. But the risks of colonoscopy do not move slowly, they happen immediately. Bleeding is one of the most common complications, particularly after polyp removal. In younger adults, bleeding can often be managed easily. In older adults, especially those on blood thinners for heart disease or stroke prevention, bleeding can become severe, sometimes requiring hospitalization or transfusion. Bowel perforation, though rare, becomes more likely with age due to thinner intestinal walls. A perforation is a surgical emergency. It can lead to infection in the abdominal cavity, known as peritonitis, a life-threatening condition requiring urgent surgery. The risk may seem small statistically, but when you are the one experiencing it, statistics lose meaning. Sedation presents another layer of danger. Colonoscopy typically involves medications that depress the central nervous system. In a 50-year-old, the body clears these drugs efficiently. In an 80-year-old, metabolism is slower. Sedation increases the risk of low blood pressure, breathing suppression, confusion, and, in some cases, prolonged cognitive changes. Post-procedure delirium is not uncommon in frail seniors. For a person already at risk of memory decline, even a brief episode of delirium can accelerate functional deterioration. Then there is the preparation, the bowel cleansing process that requires powerful laxatives and significant fluid shifts. Dehydration is a real threat. Electrolyte imbalances can trigger irregular heart rhythms, especially in those with underlying cardiac disease. For someone with marginal kidney function, aggressive bowel prep can worsen renal impairment. What is routine at 55 can become destabilizing at 82. Large observational studies have demonstrated that complication rates from colonoscopy increase steadily with age, particularly after 75. At the same time, the absolute reduction in colorectal cancer mortality diminishes in those who have been regularly screened before. In other words, the protection gained from earlier decades of screening continues, but the incremental benefit of adding one more colonoscopy becomes smaller, while the procedural risk becomes larger. That is the definition of a shifting risk-benefit ratio. This does not mean colon cancer disappears after 75. It does not mean screening is always inappropriate. It means the decision must be thoughtful. A healthy 77-year-old who has never been screened may benefit significantly from evaluation. A robust 78-year-old with a strong family history and long life expectancy may still reasonably choose colonoscopy, but an 80-year-old with multiple chronic illnesses and a history of normal colonoscopies may gain little and risk much. There are alternatives. Non-invasive stool-based tests can detect blood or DNA markers associated with colorectal cancer. While not perfect, they carry no sedation risk, no perforation risk, no dehydration risk. For many seniors, they offer a safer compromise, particularly when life expectancy is limited or procedural risks are high. Medicine is not about one-size-fits-all solutions. It is about matching interventions to individual physiology and priorities. What often drives continued screening is fear. The word cancer carries enormous emotional weight. Families worry, patients worry, physicians worry about missing something, but fear is not the same as evidence. Colon cancer is indeed serious, but so are the complications of invasive procedures in vulnerable bodies. A hospitalization after a complication can trigger a cascade: weakness from bed rest, increased fall risk, loss of independence, transition to assisted living. For many older adults, the greatest threat is not an undetected slow-growing tumor, but a sudden functional decline after a medical complication. Life expectancy is a difficult topic, yet it is central to this decision. Screening aims to prevent death years in the future. If a person's estimated life expectancy is less than 10 years due to age or comorbidities, the probability that a newly detected polyp will progress to fatal cancer within that window decreases substantially. That is not pessimism, it is biology. And acknowledging biology allows for smarter choices. The The conversation after 75 should sound different. Instead of asking, when is your next colonoscopy? The question should be, given your health today, will this test meaningfully extend your life or improve its quality? That single question reframes medicine from automatic to intentional. It restores agency to the patient. It transforms screening from a reflex into a decision. Healthy aging is about preserving mobility, cognition, strength, and dignity. Regular physical activity reduces colorectal cancer risk through improved metabolic function and reduced inflammation. Diets rich in fiber from vegetables, legumes, and whole grains support a healthy gut microbiome, which influences cancer risk at the cellular level. Maintaining a healthy body weight decreases systemic inflammation. These daily habits exert powerful preventive effects without exposing the body to procedural danger. The goal is not to abandon prevention. The goal is to practice prevention wisely. The American Cancer Society emphasizes individualized decision-making for a reason. Science has matured beyond rigid age cutoffs. It recognizes that chronological age alone does not determine benefit, but it also acknowledges that risk accumulates with time. Stopping routine colonoscopy after 75, when appropriate, is not surrender. It is an evidence-based adjustment. It is recognizing that the body's resilience has changed. It is choosing to protect function and independence as fiercely as we once pursued early detection. Sometimes the most powerful medical decision is not the one that adds another procedure, but the one that respects the limits of biology and prioritizes quality of life. And in that quiet, thoughtful decision lies a deeper truth about aging. Health is not measured solely by how aggressively we search for disease, but by how wisely we protect the years we have left. It sounds reassuring, almost futuristic, the promise of a full-body CT scan that can look inside you from head to pelvis in minutes, searching for hidden tumors, silent aneurysms, unnoticed disease, offering what feels like certainty in an uncertain world. The marketing is seductive. Catch cancer early, detect problems before symptoms appear, take control of your health. But beneath that promise lies a quieter truth that few people hear before they step into the scanner. For adults over 70 especially, routine full-body CT scans without symptoms may expose them to more harm than protection, and the science behind that warning is sobering. A CT scan is not a simple photograph. It uses ionizing radiation, doses far higher than a standard X-ray, to create detailed cross-sectional images of internal organs. Radiation is cumulative. Each exposure adds to the lifetime total. While a single scan may not cause noticeable harm, repeated imaging increases long-term cancer risk, particularly in tissues sensitive to radiation. In younger people, that future risk spans decades. In older adults, the issue becomes more complex. The greater concern is not just radiation itself, but what the scan reveals. Studies have shown that when asymptomatic adults undergo full-body CT screening, incidental findings appear in a significant percentage of cases, sometimes reported in up to 30 to 40% of individuals depending on age. These incidental findings are abnormalities that were never causing symptoms and may never cause symptoms. Small lung nodules, benign liver cysts, adrenal masses that are hormonally inactive, tiny kidney lesions. Most of these are harmless, but once seen, they cannot be unseen, and that is where the cascade begins. Follow-up scans, repeat imaging at 6 months, biopsies, specialist referrals, anxiety that lingers between appointments. Each step carries its own risks. A needle biopsy can cause bleeding or infection. Contrast dye used in some CT scans can stress the kidneys, particularly in older adults with reduced renal function. Even the psychological burden of watching a lesion can alter sleep, elevate stress hormones, and reduce overall well-being. The phenomenon is well recognized in medical literature and often referred to as the cascade effect. One test triggers another and then another, not necessarily because disease is present, but because uncertainty exists. And in medicine, uncertainty often drives action. But action is not always synonymous with benefit. In older adults, especially those over 70, the probability of incidental findings increases simply because aging tissues develop benign structural changes over time. The scanner detects age as much as it detects disease. Professional societies have issued cautionary statements regarding routine imaging in asymptomatic individuals. The American College of Radiology has emphasized that imaging should be clinically justified, meaning there should be a clear medical indication. Screening without symptoms in low-risk populations has not demonstrated consistent evidence of improved overall survival. In other words, finding more does not necessarily mean living longer. Consider the lungs. Tiny pulmonary nodules are common, particularly in older adults. Most are scars from past infections or benign growths. Yet, once identified, they may require serial CT scans over years to confirm stability. Each scan adds radiation exposure. Each follow-up appointment adds tension. And for the vast majority, the nodule never becomes cancer. Consider the abdomen. Incidental adrenal masses, often called incidentalomas, are frequently discovered on CT scans. The majority are non-functional and benign, but confirming that requires hormonal testing, repeat imaging, sometimes even surgery if growth occurs. Surgery in a 75 or 80-year-old carries higher risks of complications, including infections, blood clots, and prolonged recovery. And then there is the heart of the matter. False positives. A false positive is an abnormal finding that suggests disease when none exists. False positives lead to invasive testing. They create fear. They alter life plans. They shift identity from healthy to patient. Research across various imaging modalities has demonstrated that false positives are not rare in broad screening programs. In older populations, where structural variations are common, the rate can be even higher. Radiation exposure itself deserves attention. A full-body CT scan can deliver radiation doses many times higher than a chest X-ray. While the cancer risk from a single scan in a 75-year-old may be lower than in a 30-year-old due to shorter remaining lifespan, the immediate procedural and downstream risks remain significant. Moreover, repeated scans compound exposure. What is often missing in the conversation is the concept of pretest probability. In medicine, tests are most useful when there is a meaningful chance of disease based on symptoms, history, or risk factors. Testing low-risk, asymptomatic individuals reduces predictive value. The more you look in low-risk populations, the more you find incidental abnormalities that are statistically unlikely to represent life-threatening disease. There is also the reality that early detection does not always equal better outcomes. Some cancers grow so slowly that they would never cause harm within a person's natural lifespan. Detecting them earlier may increase the time a person knows about the diagnosis without actually extending life. This phenomenon, known as lead time bias, can create the illusion of improved survival, when in reality, the course of the disease has not changed. For adults over 70, the priority often shifts from aggressive detection to preservation of strength, cognition, and independence. Hospital visits, procedures, and complications can erode those priorities quickly. A complication from a biopsy may require hospitalization. Hospitalization can lead to deconditioning. Deconditioning increases fall risk. Falls can result in fractures. The domino effect can be devastating. None of this means imaging is unnecessary. CT scans are life-saving when used appropriately. If someone has unexplained weight loss, persistent pain, neurological symptoms, or signs of internal bleeding, imaging becomes a critical diagnostic tool. The difference lies in intention. Imaging for symptoms is targeted. Imaging for reassurance without indication is speculative. Prevention in later life is more powerfully driven by daily habits than by panoramic scans. Regular physical activity improves cardiovascular function and reduces systemic inflammation, lowering risk for multiple chronic diseases. Diets rich in fruits, vegetables, whole grains, and healthy fats support cellular health and immune balance. Adequate sleep regulates hormonal pathways linked to cancer risk. Social connection reduces chronic stress, which influences inflammatory markers. These interventions lack the dramatic imagery of a scan, but their impact is measurable and profound. Large epidemiological studies consistently demonstrate that lifestyle factors account for substantial portions of chronic disease risk. They do not create incidental findings. They do not expose the body to radiation. They do not trigger cascades of invasive testing. The desire for certainty is deeply human. We want to know. We want reassurance. but medicine must weigh certainty against consequence. A full-body CT scan in an asymptomatic 72-year-old may provide temporary relief, but if it reveals a benign lesion that leads to surgery and complications, the cost may far exceed the comfort. True preventive care after 70 requires courage of a different kind. It requires the courage to accept that not every unseen abnormality needs to be found. It requires trust in evidence, in physiology, in thoughtful decision-making. It requires asking a powerful question before any test. Will this information change management in a way that improves my quality or length of life? The American College of Radiology and other expert bodies advocate for appropriateness criteria precisely because imaging is a powerful tool. Power must be used wisely. When guided by symptoms and clinical judgment, CT scans save lives. When used indiscriminately for reassurance, they can open doors to harm. In the end, health is not about scanning every inch of the body in search of silent shadows. It is about strengthening the systems that keep us resilient. It is about movement, nourishment, connection, and purpose. It is about protecting function more than chasing incidental findings. And sometimes, the most protective decision you can make is to step away from the scanner and invest instead in the daily habits that truly shape how well you live the years ahead.